So good morning, everybody. The first thing I'll talk about is undescended testes. This slide is to basically denote that the retractile testis, and we can go into what that means, is a normal variation, and it's quite normal before the age of puberty, where a lot of testicular growth happens, and just the pure gravity effect of that keeps them from becoming continue to be retractile. Cryptorchidism, coming from the Greek for hidden testis, can mean basically one of three things. What you're used to, undescended testes, meaning they could be anywhere from intra-abdominally or anywhere along the inguinal canal. Absent testes are testes that are non-palpable and for one reason or another didn't develop correctly or suffered an ischemic event and is also known as the vanishing testis syndrome. Ectopic testis is basically, as it denotes, the malplacement or malpositioning of the testis that's outside the normal tract where you would normally find them. This diagram kind of illustrates that. On this side is the partially descended testis, where it could be intra-abdominal along the inguinal canal or prepubic, meaning right in front of the pubic bone. For the ectopic testis, it could be basically anywhere in the perineum. This is by far a more rare presentation. It could be anywhere from at the base of the penis, which we call penile, quite lateral, femoral, or even past the scrotum or in the contralateral scrotum and perineal. So undescended testes, as you know, is pretty common. It can occur in 1 in 33 live births. As you may know, it's more common in a patient that's in a newborn that's born premature, which makes sense since the descent of the testicle happens in utero. If they're born premature, then the testicles just didn't have enough time to make its way down to where it needs to be. At least 2/3, possibly more, are unilateral rather than bilateral, and most of them descend by 6 months of age. And so we should give them at least 6 months of age, adequate time for them to descend on their own if they're not descended at birth. In fact, after 8 months of age, the rate of descent is more on the order of 0.1%. And so referral at or prior to 6 months of age is appropriate. The descent of the testicle is contingent on testosterone and the action of testosterone prenatally. And so that was the rationale behind hormone therapy, but really it's more of an antiquated therapy and because it simply doesn't really work very well. Diagnosis of undescended testis is made on physical exam alone, and so routine ultrasounds typically isn't necessary. They are reserved for certain scenarios, mainly in the obese patient, in this case obese, but it's basically any newborn because they usually have a very prominent suprapubic fat pad, and sometimes it's just difficult to palpate a testicle whether it's in the inguinal canal or not. And in those patients, it's reasonable to get a scrotal ultrasound just to confirm whether it's not present, which may mean it's intra-abdominal or absent, whether it's in the inguinal canal, because that does have implications as far as how you would approach it surgically. Why would we treat? The first one, which is on a lot of parents' minds, is infertility. For unilateral testis after surgery, the paternity rate is actually close to normal. It only is affected usually if it's bilateral, because then the paternity rates can vary, but it could be as low as 60%, 62% for bilateral cases, and that's after surgery. The risk of testicular malignancy, the rate in a child that doesn't have a history of undescended testis is roughly about 0.4%. But if they have a history of undescended testis, it gets up to about 1%. Still not a lot, but higher than the general population. And we counsel the patients that even though we do an orchidopexy and bring the testicle down, that malignancy risk doesn't decrease after the surgery. It remains the same. The only difference is that in the appropriate position, you prevent further maldevelopment in the future and that sort of thing. And it's in an area where it can be easily examined. And so if a testicular cancer or tumor were to arise, you'd be able to catch it. Inguinal hernia is almost always associated with it, because when the testicles descend down through the canal, it drags with it multiple layers of the abdominal wall, including the peritoneum, which is basically the hernia. And so every newborn with undescended testis has it. And so when we do an orchidopexy, we expect to find a hernia and repair it at the same time. When the testicles descend and reach the scrotum, they typically fixate to the surrounding tissues in the scrotum, and so decrease their risk for testicular torsion. And so patients that have an undescended testis are a higher risk for that because they don't have the luxury of that fixation. And there are kids that come in and they have they have growing pain, redness, and it's found that they have an undescended testicle, and the undescended testicle is undergoing torsion and require emergent surgery for it. Because it can be located right in front of the pubic bone, the area of the scrotum is kind of a relative area of protection. And so any trauma or blunt trauma to that area, it moves out of the way. But if it's static within the inguinal canal, there's a higher rate, albeit very still low rate, that it may be injured against the pubic bone. And then of course the stigma of, or possible stigma of having an empty scrotum. So surgical intervention, it's a balance. You want to give it adequate time if they're undescended to descend on their own to avoid surgery. And so you should give them at least till 6 months of age. 8 months, 6 to 8 months, around that time. The decision to try to take care of it before 2 years of age is twofold. One reason is because around a year and a half to 2 is when the patient has more what we call genital awareness. And so doing surgery after that age of genital awareness, they tend to have a tougher time. I mean, having said that, there are many kids that we do past 2 years of age, and we get them through it, but they tend to have more discomfort with it. And the babies, infants that we do at the younger age, a lot of them, short of maybe some fussiness the first day or two, they act like nothing happened. The other reason is that there have been large studies in Europe where it has shown that as early as 2 years of age, you can see histologic changes within the testicle due to the abnormal position. And it's obviously that it's hard to tell what clinical implication that has, but the idea is that if there is change, then there's that potential for injury. The approach depends on what the characteristic of the exam is. If it's non-palpable, meaning it could be absent or intra-abdominal, and then they typically undergo a diagnostic laparoscopy to confirm to see if it's in the abdomen. And depending on how high it is in the abdomen determines whether it's a staged approach or not. So they may require two separate surgeries to bring them down ultimately into the scrotum. If it's palpable, it's usually in the inguinal canal, and so they undergo orchidopexy via either inguinal or scrotal approach. Next thing I'd like to talk about is hydroceles. Hydroceles or hernias, similar thing. It's much different than the adult type hernia. It's all based on delayed closure of the processus vaginalis. As I mentioned earlier, testicles descend from the abdomen and it drags a lot of things with it, including the peritoneal lining. And so that becomes the processus vaginalis, which surrounds the testicle and the spermatic cord. And once it reaches down into the scrotum is when this process begins to close. And so if they don't make it down to the scrotum, oftentimes it doesn't close. But in some boys, even despite descending all the way to the scrotum, it doesn't close completely. And it varies on how much. And so the classical presentation you may have seen many times, the classic is transillumination. If you shine a light through the scrotum, it'll shine through and shine red. And this typically is not associated with any pain or discomfort. There usually isn't any redness or signs of cellulitis of the scrotum, and it typically resolves. Ultrasound in this instance isn't necessary. Many resolve spontaneously. A reason to do ultrasound in our practice is that if, like the previous depiction, if the hydrocele is so large that you can't examine the testicle very well. And so the ultrasound in that regard is to determine and ensure that that testicle appears and is normal. Indications for surgery, which would be a communicating hydrocele, the way you would determine that is oftentimes by history. You can see it on exam sometimes when you compress the hydrocele and you see that the fluid decreases. And then sometimes you can have the patient, if the patient's fussy or cries, you see it balloon back up. That means it's a pretty large communication. You don't always see that, and sometimes you have to rely on history. When the parents come in, I typically ask them, do you ever see this fluctuate in size? Especially in the little older kids, past 1 when they're running around, and it may be larger at the end of the day, but then when they first wake up in the morning, it's not there. And so those are important history points. Failure of resolution, typically we give them, and it kind of depends. As we follow them along, sometimes they will report that the size seems to be decreasing as we go along. And if that's the case and that's the trend, then I typically keep them on that path to observe. Usually give them, past a year of age, even up to 2 years of age before. I always give them the option to repair it sooner, because some parents have a great deal of anxiety with this. Especially if you tell them that this could progress into the latter point, a full-blown hernia and incarceration and all the things we counsel them on. And some parents just have a lot of anxiety, feeling that they get stressed out having to always observe for that and worry about that. So if there's a significant inguinal component, a lot of swelling along the groin, that's an indication that the communication is pretty large, and it probably won't close, and so can be an indication to surgically correct it. Next is testicular torsion, which many of you are probably very familiar with. And so what I wanted to touch on are the kind of variations of torsion that sometimes are a little trickier to manage. The one you're usually used to is the older child, which in this, there's no true clinical implication of this. This is just kind of in the testicular torsion in the adolescent that we're used to. It's intravaginal torsion, meaning the testicle twists within that tunica vaginalis that surrounds the testicle, whereas in the neonate, it's outside of extravaginal, so it's the entire thing twisting. And so neonatal torsion can be divided up into two events. One is the patient happening prenatally, and they're born and the testicle is already lost. And you can see that because of that, the testicle is usually non-salvageable and becomes less of an emergent thing to deal with. The other is postnatal, within the first 30 days of life after a normal exam. Usually that's when you usually see the other manifestations with the scrotum, skin changes, the testicle may be high riding, some redness, and there may or may not be some tenderness associated with it. But the ultrasound findings remain the same. Salvage is possible in the postnatal period, but I would say very rarely do we find it at this phase. It's usually at the prenatal phase that we see it. This is just a typical ultrasound showing that on the left testicle here there's heterogeneity, and then this is with Doppler flow, so there's no flow within the testicle. This is, again, a transverse view where you can see both sides, and you can see that the testicle is heterogeneic and, again, no Doppler flow. This hydrocele may be reactive. Sometimes you can see a contralateral reactive hydrocele resulting from it, or it could be normal, because if it's a newborn baby, many of them have what we call newborn hydroceles, which resolve without any problems. That's probably what you're seeing here. Intermittent torsion is the other thing that is hard to diagnose. It's the adolescent boy that comes in and has these intermittent periods where he complains of testicular pain, usually unilateral, but then it resolves, usually in a few minutes. Some of them last up to an hour, maybe even 2. But then they're interspersed with intermittent periods where they have no symptoms. Like its counterpart, persistent torsion, they may have nausea and vomiting, because this pain can be quite severe. It's hard to diagnose because oftentimes when they come to see you, they don't have that pain currently. So if they don't have the pain, if you did an ultrasound at that point, they'd have normal blood flow, and it's hard to diagnose. And so you have to rely a lot on the history. This just depicts why this happens. The normal testicle is more of a longitudinal axis, something called the bell clapper deformity, which is the little clapper within a bell, how it's arranged, where the bell is at the bottom of the spermatic cord, and it's more of a horizontal lie. And then when it's in that configuration, it has more tendency to twist. And so when it twists, it shortens the spermatic cord. This comes up, and that's why you get the high-riding horizontal lie of the typical testicular torsion. On the scrotal ultrasound, they look for the spermatic cord. They look for what's called a whirlpool sign, which is this sign, and basically it's that twisting of the cord that they see. It's not always there, but they always try to look for it. Then you get a boggy, thickened cord. The role of elective surgery, obviously, is to provide pain relief and avoid potential testicular injury, or the conversion to persistent torsion, where they come in and they have the same surgery, just under an emergency situation. That's what we try to avoid. Follow-up, persistent scrotal pain, even after surgery, I always counsel them and say, look, there's a chance, because we're basing this mostly on history, there's a chance that this may not be the source of your scrotal pain. And if that's the case, we do the surgery, you may continue to have scrotal pain, in which case we'd have to reinvestigate. And they have to understand that, or it's setting their expectations, where if they come and they think this is the solve-all, and then they get this elective surgery and they still have pain, and they're incredibly disappointed. And it's all to avoid recurrence and size discrepancy. And it's normal to have a little bit of a size discrepancy, but the idea is that if there's intermittent torsion, recurrent ischemic events, that this size discrepancy may be pronounced. So the last but not least is the urinary tract infections. I'll try to go through this quickly. As you know, the signs and symptoms are very different whether it's an infant versus an older children. Infants, as you can see, it's very non-specific symptoms, ranging from fever to fussiness, to changes in PO intake and whatnot. The big one is fever, because those are the ones we think that involve the kidney and maybe pyelonephritis. Key test is the urinalysis. We should always get a urinalysis. The problem is that the test is not perfect, and the first thing you should look at, and I highlighted these three in all the things that are looked at in the urinalysis. Anything past this point basically could indicate dehydration. And the reason that's important, because oftentimes they come in and they are dehydrated, and they're in this range. And the reason that's important is because when they're dehydrated, all these other parameters that we rely upon to diagnose UTI can also have false positive. And so that's something to keep in mind. When nitrites and leukocyte esterase, which is a marker of inflammation or pyuria, are both positive, the sensitivity of diagnosing UTI approaches 100%. But when they're both negative, the negative predictive value also approaches 100% as far as diagnosing UTI. The reliability of urine specimens, as you can imagine, the more invasive it is, the more accurate it is as far as determination of UTI. The bag specimen is only useful if it's negative, because then if it's negative, you don't have to go any further. The problem arises when it's positive, because it's positive, you don't know if it's contamination or whatnot. The bag specimen is often perceived as something that's easier, but in truth, it's actually more labor intensive if you do it correctly. You have to wash hands, you have to wash the skin, you have to put it on there. If there's no production after 3 hours, you have to change it. And once you get the bag specimen, you have to send it within 15 minutes. There's a lot of things that go into it to increase the validity of it. And so it's, in essence, sometimes it's not the easiest thing to do. Uncircumcised boys, there's a higher risk of colonization of the foreskin, and so there's higher risk of contamination in uncircumcised boys. And in fact, their UTI risk is much higher in the newborn phase, but after 3 months of age, that risk progressively becomes lower and lower until at 1 year of age, it's almost equivalent to their peers. The main take-home points for UTI, not only do you need bacteriuria, but you also need pyuria, and that's what you see on the urinalysis. A febrile UTI, we worry that it's pyelonephritis, because if it's a bladder infection or cystitis, usually it's not accompanied by fever. Catheterization is more accurate than bag specimen, but there is a role for bag specimen, as I measured before, and the first line imaging is renal ultrasound. Afebrile infections, especially if they're recurrent, we have to start thinking about voiding dysfunction and constipation as confounding factors that contribute to that, and then when to refer. Febrile UTIs to rule out underlying causes, the second UTI as recommended by the American Academy of Pediatrics, second febrile UTI for girls, and the first UTI in boys, which I think can be tempered depending on the boy's age. Like I mentioned, in newborns, uncircumcised boys have a higher risk of a UTI. Abnormalities on imaging, on the ultrasound or VCUG, and then if there's any suspicion for disorders of elimination, recurrent afebrile UTIs, there's a specialized program, because it's so prevalent, that we call the Voiding Improvement Program, or VIP, that we refer kids to. When should you refer a patient with undescended testis to see the urologist? Great. So yes, it's 6 months of age, or it could be any time before that if the parents just have anxiety about it, and you don't, or it seems like they're not happy with your explanation, or they want more information. I'm happy. We're happy to see them. We're happy to see them at any time. Somebody's here. So the next one, 12-year-old girl with spina bifida who performs clean intimate catheterization presents to your office for a well-child visit. During your visit, she reports foul-smelling, cloudy urine without any other symptoms. How do you proceed? Great, but this is a good teaching point then. The answer is actually C. Don't feel bad. I mean, it's easy to get caught up in any of these other answers. And the only reason I know the answer is because this happens to be my focal and interest area, and specifically in the spina bifida population, because it's tricky. These kids by far have the highest risk of colonization. If you checked a random urine culture, it'd be at least 8 out of 10 times it would be positive. And so the question is whether to treat that. That's why the urinalysis is so important. But in the absence of any symptoms whatsoever, because especially since foul-smelling urine can be, can mean a lot of things. It could be the inefficient emptying when they catheterize, so there's still urine and it becomes cloudy. But it doesn't necessarily mean it's a problem. It may be a manifestation of the colonization. And so, if you want, we can go over this in more detail at the break. But it is really just to push the fluids, because when you push the fluids, whatever's there, the colonized bacteria that's there, you dilute it. And then you push the fluids, the bladder gets full, they catheterize and they get rid of it, no big deal, it's done. And so this is always a good start. And then you push the fluids for 24, 48 hours, and most of the time it clears up. And then you avoid antibiotic treatment, you avoid further testing. If it doesn't, then that's when you have to reevaluate it. And I always offer to the pediatrician, because this becomes a problem in this patient population, I say that if you're unsure, reach out to us. We can help you determine, whether it's appropriate to treat, and we have, criteria and symptoms and all that. And so that's that. Thank you very much.